Yeah, absolutely.
All right, so we have Dr. LeVesseur presenting our third part in this series on pain management. And with that, we'll let you get started.
Okay, wonderful. Thanks, Aaron. Okay, so yeah, I am Brett LeVesseur. I'm graduated from the fellowship about 3 years ago with Aaron, and I had done a part of this lecture when I was a fellow, and it was only on low dose naltrexone. And then a year ago, John had asked that I kind of expand on that and do additional um, conversation on some other things that may not have been discussed in previous lectures, and maybe also some new things that we have discussed, but maybe expanding on a few different things. So that's sort of my goal during this lecture, is to present a few interesting facts on some medications and some non-medication approaches to pain management. So my hope is that you'll learn something new, or I can share some clinical pearls that I've learned along the way. So we'll get started. Got no disclosures. And the learning objectives for today, I have 6 things that I'm going to touch on. As I've already mentioned, low dose naltrexone is something that I'm going to discuss. Some of you guys, if you've seen last year's lecture, you would have heard about it, but if you haven't, you may be surprised to hear that this is something that we use for pain management. I'm also going to discuss tricyclic antidepressants, NSAIDs. There's a journal article that's regards prodrugs and SSRIs in pain management, which I found very interesting. We did a journal article on it as part of our at Trinity Health. We do journal articles every couple weeks, and then I want to touch on some things about tramadol, and then lastly, non-pharmacological treatments to pain management. Started with low dose naltrexone. So this slide is just a real simple slide. It kind of just tells you the facts that I think are probably most important to remember. Low dose naltrexone, as it sounds, it's low dose, so 4.5 milligrams. If you have any experience using naltrexone for other uses, you know that that is about a tenth of the size that's normally prescribed. We're going to get to that in a second. It's used primarily for chronic pain, but it has been shown to possibly help with fatigue and mood. Its side effects include vivid dreams for the most part, abdominal pain, nausea, and headaches. I suspect that those last side effects are primarily just from taking a pill by mouth, because when you look at those side effects and you compare them to placebo, they're about the same. But the vivid dreams does seem to be unique to low dose naltrexone. Not a deal breaker for most people. It's not, usually they're not scary dreams. They're just, people just say they dream more and they remember them more. And then lastly, it's a compounded med, which means it's not as easy to get your hands on, though. We do have a compounding pharmacy in the community with Keystone, so it's um, as long as you know where to get it. I've also gotten it on uh, pharmacies that I have found online. I had a patient who we were starting it with, and Keystone's charges about $45 for this medication per month. I think if you talk with them, they will work with you. But the pharmacy that I found online, was very easy. I just made a phone call, and it was a third of that price. So for $45, I got 3 months, and they shipped it to the patient's house. So let's get into some more of the details about low dose naltrexone, because I actually had a PM&R doc tell me about this medication many years ago. I was still, I believe, a med student, and he had mentioned it, and it surprised me because from what I knew about naltrexone is that it just didn't make a lot of sense. You have, if you know, we use naltrexone. What I had seen it used for was for like alcohol use disorder, and those doses were like in the 50 milligram dose range. And so I knew that naltrexone, like something like Narcan, was an opioid antagonist. So it was just kind of surprised me that they this physician had mentioned that it was being used for pain because it just didn't make a lot of sense. If you have somebody who's taken too many pain meds and you give them Narcan, well, you reverse all that and they're suddenly in a lot of pain. So the idea that you give somebody an antagonist on the mu receptors and their pain's going to get better just seemed counterintuitive. But that's actually where the low dose comes into effect. So the doses, as I mentioned, for addiction are typically around 50 to 100 milligrams, whereas low dose for naltrexone refers to doses anywhere from probably half a milligram to 6, but most patients will probably land on about 4.5 milligrams. And there's also some literature that describes the use of an ultra low or very low dose, which is maybe around 100 micrograms per day. And I had seen some medications that were used in Europe actually, where they were combining an opioid along with low dose naltrexone, and it was shown to possibly be beneficial in things like preventing side effects like constipation. But those drugs really never made their way over here. So let's talk about why low dose naltrexone seems to treat pain, even though it's blocking the receptors that help regulate pain. And that's primarily because it is so low dose. And when we give that low dose, it binds to just enough mu receptors where it actually seems to kind of encourage the body to produce its own endogenous opioids. So I think that's really, really interesting. And um, so it's almost like a paradoxical effect. And you kind of trick the body to thinking that it's not producing enough of its own endogenous opioids, and then it upregulates those. And of course, we feel better. What are those endogenous opioids? They're things like endorphins. We all know about like a runner's high. And so it makes sense, I guess, theoretically, that it could help with people's pain. It also appears to work on glial cells in the brain, which is different. And there's an article through Stanford. They were the first, I think, serious researchers that actually were taking a look at this. And this was about 10, 15 years ago. And I remember reading an article and they describe this, the modulation of the glial cells as sort of they used the word novel approach. And I haven't seen any other meds that have used through that mechanism, but the glial cells are typically, so they're cells in the brain that provide a supportive role in the brain. So help create like homeostasis, forming myelin, and providing support and protection for the neurons. And these are things like astrocytes or Schwann cells. And they also bind to receptors that help with creating inflammatory mediators, such as IL-1 and uh, TNF alpha. There was an article that I found last year, or about 2 years ago when I did this lecture, and I included part of those slides. I took them out this time, but I thought it was very interesting because they followed patients over about 6 weeks, and they actually found that several of these inflammatory mediators actually decreased over time. And so you can see this with patients, and there is some evidence that patients with elevated inflammatory mediators like CRP and ESR may get more benefit from low dose naltrexone. The other mechanism is a little more complicated, but it is through essentially dopaminergic receptors. And there's some thought that that may be playing a role also in the mood aspect, people feeling like they're happier, their well-being's increased. I don't know. I think that's probably an aspect to it, but I would imagine that primarily that's through the opioids receptors, the mu receptors. Now, I'm going to be honest with you. I've used this maybe a handful of times, not even probably 10 times, over 10 times. But I have spoken to some other physicians who have tried it. I've had mixed results. And I think probably part of that is because we're not exactly sure where the role is. And when we treat just chronic pain in general, I imagine we are going to have patients that it's just not going to be helpful for them. The other aspects that I find challenging is that I work in the inpatient setting. And so the patients I tend to see are in a lot of pain. We don't get consulted unless they've got uncontrolled pain. So This medicine takes time, and so it's not something you're going to reach for right away. And it's difficult in the inpatient setting. You can start it in the inpatient setting, but then trying to find a physician or a clinician who's going to continue that in the outpatient setting might be challenging because I've asked a lot of physicians and clinicians and other providers if they've ever heard of this medicine, and I've had, to be honest, one physician tell me that they have. So it might be challenging, but I think if you're in the outpatient setting, something that you should have as an option. And I actually updated these slides this year because I wanted to provide what there was a couple studies that I had seen that I thought were relevant, and I took away some of the other stuff. Um, I think the most important thing you should know about LDN or low dose naltrexone is that it is, you know, there is some limited evidence that it may be helpful. It's, I think when it's not first line. So if you're considering it, it's probably because you've had other meds that have failed or just not adequate enough. But I think it's worth a try. If you have the right patient, say you have a patient who you don't want to start opioids with, this might be a great option because you might get some of the opioid-like effects without all the side effects. Say a young patient or an elderly patient. I think if you're considering something like buprenorphine, this might be a step below that. So the evidence for pain management in general is fairly mixed. The evidence for fibromyalgia seems to be a little more supportive. But there are studies that show that it helps, and then there are studies that show that it doesn't. The most recent meta-analysis that I came across showed that there was some modest reduction in pain and in some improvement in quality of life. And I'm going to discuss that study here in a moment. There also have been a recent randomized control trial which showed that there was no difference in pain relief after 12 weeks. Okay, so this is the meta-analysis that I'm referring to, and this is just generally for chronic pain syndromes. They found that the evidence based on all the studies that they looked at did show that there was a modest effect. Now, this effect size of negative 0.34, that's considered small to moderate. Anything from 0.3 to 0.5 is considered small to moderate in that range. So there is some pain relief there. It's just not a dramatic effect. The question I had when I saw that was, what does that mean? What's an effect size of 0.34? And so I started to look into that a little bit and seeing what the effect size was for some other medicines that we have. And I came across an article through JAMA 2022 where they compared several different FDA-approved drugs for fibromyalgia, and they were comparing that, so amitriptyline with the FDA-approved drugs such as duloxetine and pregabalin. There were some really actually quite interesting things that I found in this article, but to get to the effect size, duloxetine has an effect size of minus 0.33. Pregabalin is 0.3. So they're right around where this low dose naltrexone is. I'm not sure exactly what to do with that because I have seen patients get better on duloxetine and get better on pregabalin. Some of these studies are suggesting that LDN is not as helpful, but yet they still seem to have the same effect size. So there may be some, may be helpful for some people. Some of the things about this article that I thought was actually quite interesting, and the reason I bring them up is because we're going to talk about tricyclics, but they talk about amitriptyline, and I want to read a little quote that they had here because this kind of surprised me. They were referring to adverse effects, and this was for fibromyalgia patients. They said amitriptyline did not differ from placebo in terms of adverse effects, while all other treatments were associated with a lower acceptability. That surprised me because tricyclics generally have the most side effects. So thought that was quite interesting. They also showed that amitriptyline was associated with greater improvements in sleep, fatigue, and quality of life, even more so than pregabalin. That does not necessarily surprise me. I think that I have seen amitriptyline as quite sedating medicine, and it does help with sleep. Let's see. So duloxetine, out of that study, 120 milligrams was associated with the highest improvement in pain and depression. Okay, so The next one is that study. This is actually through Lancet, and this was the rheumatology journal. And the last year, they used 6 milligrams daily, and this was for women with fibromyalgia. And it was a randomized, double-blind, placebo-controlled trial. They had approximately 100 patients. They split it right down the middle, and the mean difference in pain scores was a minus 1.3 in the LDN group and a 0.9 in the placebo group. So unfortunately, they concluded in this study that LDN was not superior to placebo in relieving pain. And that kind of surprised me because I've seen, like I said, I've had mixed results, but I have seen people get better on it. It's not huge, but there is an effect there. This may also, I don't know how long uh, they, how long a placebo effect like that would last. Perhaps if you studied it long enough, you would find that the LDN group was more sustainable. But 1.3 is not a huge change. So we're going to summarize one more time. Low dose naltrexone is low dose, so 4.5 milligrams. And actually, let me mention something about that dose because there is another study that was done by the same people who originally started looking at fibromyalgia and LDN, and did a very interesting study where they were using different dosing, and it was randomized for the patient. And over time, if patients got better, the dose would change, or over time it would change based on their perception of the drug. And most patients landed on about 4.5 milligrams. It wasn't 6, and it wasn't lower. So 4.5 milligrams is probably the right dose. If you're going to start it with somebody, you can start 1 or 2 milligrams and then bump it up after that. I generally think it's probably fine just to start them at 4.5, though. I don't really think that it kind of complicates things if you're trying to ease them into it. If they have side effects like the vivid dreams, then I think maybe, and that's concerning for them, that I think you can always back off a little bit and have them on a lower dose for a couple weeks. As I mentioned, it treats chronic pain primarily, but there is some evidence that it can treat fatigue and mood. There was actually the study I just showed about the 6 milligram dose. I didn't mention this, but the one interesting, I'll go back real quick because it's not on my notes. I thought it was. They actually suggested, oh yeah, I saw it in the very end. I didn't read that. The study did not show that it was superior to placebo, but it might improve memory problems associated with fibromyalgia. That was the first time that I had seen that. Unfortunately, the study just wasn't powered for that, and it wasn't the primary outcome, so they weren't able to make that conclusion. But they found no help for pain, but they found that it may help with memory, which I thought was kind of interesting. So I think that just really kind of confirms what I said in the beginning, which is that the results are sort of mixed. But if you're running out of options, or you have a patient who you don't want to start opioids with, or someone who doesn't want to start them themselves, a younger person or somebody who's elderly, I think this is a medicine that you should at least consider. And I have seen help with patients with headaches. And I actually have a quick story I'll share because I thought this was kind of neat. About 2 years ago, so a little bit outside of my fellowship, I had a patient who she was very sick from cancer. And I had helped, the husband was there bedside every single day. And at one point during the initial consultation, he had actually asked me if I knew anything about low dose naltrexone. This was the first time a patient had ever asked. And fortunately, I just gave the lecture not too much about 6 months earlier. So of course I was able to share a ton of information with him, and his eyes like lit up. He had never had anybody that knew anything about it. Because when you go online, there's a lot of information out there, and it kind of, I think it really presents the drug as if it can treat a ton of different conditions. And there is some evidence that it may be helpful with things like autoimmune disorders, or like things like Crohn's or even MS. So he had kind of gone down that rabbit hole, and he came to me thinking it was going to be this incredible drug that could help her. We did end up prescribing it for her right before she left because he had asked several times. Uh, I had seen her like about 9 months later, and she wasn't doing so well. I remember when I saw him, he came up to me. It was kind of interesting. He had his shoes off. At the time I had really long hair, and he came up and he said, "Oh, it's Jesus." And he was so happy to see me. And I had built trust because I had been willing to meet him where he was at. He thought that low dose naltrexone had had a huge impact for his wife, that it had helped her with her cancer and her pain and her blood levels. And I'm not sure I was convinced of that, to be quite honest. I'm not sure it did everything that he thought it did, but because I knew about this drug and it was he he instantly trusted me. And when we had to have further conversations about where she was at and about her decline, he was really open to having those. So thought that was really interesting. Let's move on. We'll talk about tricyclic antidepressants. I think this is kind of an interesting topic. The reason why is when I got out of med school, I had been taught for so long that tricyclics were not a good medicine, that they had all these problems, that they were bad for the heart, ton of side effects. And then when I got into clinical practice as a resident, I found that a lot of patients were on tricyclics and I was sort of confused. And what I began to realize actually was that tricyclics, the doses that we have people on now are quite different than the doses we used to have people on. So we used to treat patients for depression with tricyclics before we had SSRIs, and they were on much larger doses, 200 plus milligram doses. And so it's understandable to know why there were a lot more side effects and why people probably didn't like the drug as much. Most people nowadays that I find are on pretty low dose. They're on 10 to 25 milligrams, maybe as high as 75. And so I have found that actually tricyclics can be very helpful and they have a pretty good effect on people. And as the study I just referenced before is that it may actually be more tolerable than I actually personally have seen in practice. And I think that has to do with the doses that we're using. So how do tricyclics work? They're primarily through inhibition of the reuptake of norepinephrine and serotonin. They also do quite a bit more. So they block histamine, block alpha adrenergic receptors, and muscarinic receptors. That's actually where a lot of the side effects come from. So you can use tricyclics for a ton of stuff. And I think that's because they hit on so many receptors. It sort of reminds me of Zyprexa. We use it for nausea. We can use it for mood. You can use it for anxiety. It helps with sleep. It helps with appetite. So tricyclics kind of fall in that same category. It's been used for chronic pain conditions, neuropathic pain specifically, headaches and migraines. It can be quite helpful. Fibromyalgia, low back pain, even GI issues like IBS. It's I've seen protocols for amitriptyline and cyclic vomiting syndrome. It of course can help with sleep. As I mentioned, amitriptyline can be quite sedating. So it's FDA approved for depression and for OCD. Personally, I try to keep any dose below 75. And I think that's probably even a little high for some people. If I can get somebody on a dose of 10 to 25 nightly, I think that's kind of a perfect dosing. Any of the sedating effects, they tend to sleep off. So I do have some patients who say they wake up feeling a little bit fatigued. So it's something to think about. Side effects. If you've used tricyclics, you'll find out pretty quickly that a lot of people do have side effects. Fortunately, the main ones are mediated primarily through cholinergic receptors, and those are things like blurred vision, which I have seen. People describe sort of challenging to kind of focus their eyes. They get kind of almost like they get tired or weak. Constipation, that's a big deal if you have people on other medicines like opioids. Dry mouth, confusion, specifically for the elderly, urinary retention, and tachycardia. There's also orthostatic hypotension, dizziness are other ones. And then, of course, we mentioned the sedation and affect appetite, weight gain, confusion. There are some more serious ones that I mentioned earlier, the cardiac effects can be QTC prolongation, even sudden cardiac death. Another thing that is worth mentioning is that if you have somebody on tricyclics, you're looking to get them off of it, possibly because of side effects, or you just want to try to reduce polypharmacy. About 40% of the patients that have been on tricyclics chronically have some type of discontinuation syndrome. So they might feel dizzy or can't fall asleep, headaches, flu-like symptoms, achiness, restlessness. That tends to be around for about 2 to 5 days, but it can last even up to a couple weeks. The side effects. As a resident, I want to mention this because I think this is a good way to remember sort of some of these side effects that you will come up. And when I have students or residents, I tend to uh, mention this, but there's a mnemonic out there for tricyclics and for anticholinergics, and it's mad as a hatter, blind as a bat, red as a beet, hot as a hair, and dry as a bone. And I think keep that in the back of your mind because those are the things that you're probably most likely going to see. So when I was a resident, I thought, well, amitriptyline seems to be a good med for a lot of people. We're using low doses, we're minimizing side effects, but I'm still seeing people with sedation, brain fog. They're coming in feeling sort of like it's dragging them a little. I had a guy who came into the hospital and he told me I was there for pain. He said, what's most important to me is I just want to be able to play with my grandkids, but I'm so tired all the time. And I looked at his med list and I thought, man, this guy he's a huge list. He's certainly has polypharmacy. And so that was actually one of the things that I started to do in the hospital. I talked to him about this and I reduced some of his other meds, but I also brought up that maybe we could switch his amitriptyline, that maybe his amitriptyline was causing some sedation. He had pretty severe neuropathy, so I felt that we had probably best to keep it on. But I have in the past asked myself, you know, is there other tricyclics that may be better suited for neuropathic pain other than amitriptyline? Because that's just the med I saw all the time. I had never prescribed anything differently. And quite honestly, I couldn't remember anybody else that had been on another tricyclic. So I started to do a little bit of research and I came across nortriptyline, Pamelor, which a lot of us have seen, I think. I had not seen a lot of it before that, but I came across a really interesting article from a Canadian family medicine journal. And this was back in 2018 when it was written. This physician made the argument that if we're considering a tricyclic, we should probably consider nortriptyline, possibly over amitriptyline. And the reason why is because when you take amitriptyline, it essentially gets converted to nortriptyline. But nortriptyline has a lot less side effect profile. And it has to do with its pharmacology, its chemistry, but it has a lot less sedation, a lot less hypotension, and it actually is safer cardiac wise. And so when you got an older patient, you're worried about using tricyclics and the sedating effects, the hypotension, you probably should consider nortriptyline. And I almost exclusively start with nortriptyline if I have a patient who cannot sleep at night or one that has a lot of anxiety and we're using like Atarax and stuff. I will consider amitriptyline in that setting, but I tend to think that it's almost a little too sedating for patients. And I think in my experience, nortriptyline has been just as helpful. And again, I'll use doses that are pretty low. So 10 to 25 is my preferred dosing. Next topic is NSAIDs. I included this topic because I found as a resident and as a fellow, and then even as an attending, that there is some apprehension in the hospital to use NSAIDs. And I thought, well, we should maybe touch on this topic a little bit. I won't spend a ton of time on it, but understandably, NSAIDs can have a lot of big side effects, and they can be kind of scary for some of our patients. And the patients we're seeing in the hospital are pretty sick, and so they're the ones that are probably highest risk for having the side effects from NSAIDs. But to be quite honest, I tend to think, NSAIDs are over the counter. We allow people to take them outside the hospital, but somehow when they come in, we don't want to touch them. And I think they're helpful meds. So I think it's an important topic. And I found this article a couple years ago. It's for acute pain management pearls for hospitalists. And the clinical pearl number 3 that they had discussed in here was basically that NSAIDs or anti-inflammatories, there's not a lot of good reasons to withhold them, and we should really start considering them more often. So let's talk about sort of the things that we get nervous about and what different clinical presentations we might want to consider it. So we know, I think we all know how NSAIDs work. They're primarily through the COX inhibitors, COX-1 and COX-2, and they affect prostaglandin production, which mediates inflammation and pain and fever. COX-1, so I think the biggest side effect we likely see, and the one that seems most obvious to us, is the GI risk. Those are ulcers and bleeding, and we have all seen it. And I imagine some of our ER physicians probably have seen it more than anybody. But it can be very serious, and that is primarily through inhibition of COX-1. So those prostaglandins are actually used by the gut lining in the stomach to promote secretion of mucus, bicarbonate, which helps neutralize acid. It also can affect the blood supply to the mucus that can make it more, uh, you know, that actually helps with tissue repair and protection, so it can make it more prone to having the bleeds. It also increases acid production. It can have a direct irritant effect on the stomach lining. Then it affects platelet aggregation, of course, and so that would increase risk for bleeding. What do we do? How do we mitigate those side effects? I think number one, you can use a COX-2 inhibitor. Celebrex is a good option. That's what I use because that's what I have experience with. Tend to use lower doses if I can. What I like about Celebrex is it's 1 or twice a day, and I do dosing of 1 to 200 milligrams 1 or twice a day. I try to stick at about 100 milligrams twice a day. And I think dosing things twice a day is much easier for patients to use. You use something like ibuprofen, you're kind of dosing it maybe 3 or 4 times a day. The other things is to consider risk factors. So age, do they have a history of ulcers? If you're going to start an NSAID, you should be asking this. Do they have other medications that may prevent them from using it? You don't want to combine steroids with NSAIDs. Also, other meds that you want to be aware of is anticonvulsants and SSRIs. So the combination of those two can lower the threshold for seizures. And also, NSAIDs can affect the metabolism of anticonvulsants, and you may increase GI risk of bleeding. So be careful with that. It's not like you can't use it, but I think it's something to be aware of. If they're got several risk factors and they're on anticonvulsants, you may want to think differently. Also, I don't think a lot of people know that the combination of NSAIDs and SSRIs can have an effect. So both of those meds affect platelet function and increase bleeding risk. SSRIs specifically reduce platelet aggregation. NSAIDs interfere with platelet function through the COX-1 inhibition. So that combination is particularly increases the risk of GI bleeding, specifically ulcers, and that's much higher in the elderly. There has some evidence that there might be even up to 2 or 4 times the risk for GI bleeds. And then lastly, you can always use a PPI, and that can help mitigate that risk. So those are some things that I think we should consider. Other side effects that we should definitely be aware of is cardiovascular and renal effects. Cardiovascular wise, I guess if you've been in practice long enough, or you're aware that in the early 2000s there was a recall for Vioxx, and there was concern for an increased risk for heart attacks. So they pulled that drug. And so that is something that we should be careful with. And renal effects, obviously, if somebody's coming in with an AKI or CKD, you want to avoid NSAIDs because they essentially reduce the blood flow to the kidneys. And we've all seen patients who have come in who have been on NSAIDs chronically, probably bigger doses than they should have been on, and they've come in and now they have an AKI. Okay, so this article continued. It addressed several different concerns that physicians might have, and clinicians, providers in general might have. So I kind of picked the ones that I thought would be worth discussing. So we kind of talked about the bleeding risk here. The evidence for it shows that bleeding times and perioperative bleeding events just are not significantly affected when you're using short-term doses, so 7 days or less. And so you also can consider a COX-2 inhibitor like the Celebrex. So they recommend not withholding NSAIDs for acute pain due to bleeding concerns if used in the usual doses for short durations. And then consider using a COX-2 inhibitor for high-risk patients. The other concern is wound healing. And I saw this actually in orthopedic procedures. So you get a knee replaced. Sometimes, that surgeon doesn't want to use NSAIDs. But I'll be honest, I haven't seen that lately. And I actually reached out to an orthopedic surgeon. This was a couple years, maybe 3 years ago. And it was interesting because he said, look, if there's a orthopedic surgeon who is preventing you from using an NSAID after knee surgery, they don't know where the literature is at. They're not up to date. And but so I don't see physicians really that surgeons that prevent you from using it. Usually, if I'm in the hospital and I'm considering using NSAID, and I'm not sure based on the patient's history, I typically will just reach out to the surgery team and I'll just say, are you guys okay with me using it? I don't want to start something and then have them, feel like that was the wrong decision. And so it's easy enough just to reach out to them. If it's a neurosurgery patient, I don't ever start NSAIDs because they're pretty much across the board don't want to. This suggests that may not be like fusion surgeries, that may not be necessarily the case, but still I don't use it because I just don't think that those surgeons have really been open to it. Now, the other concern is, of course, the cardiac stuff we talked about, and they do suggest that avoiding COX-2 inhibitors in cardiac surgery patients is a good idea. And then, but they're also saying that if it's a non-cardiac surgery patient, that NSAIDs, non-selectives like ibuprofen or other COX-2 inhibitors like Celebrex are probably safe in that setting. The other thing that I think I have seen before when I was a resident, and so I thought this was important to bring up, was that larger doses are really necessary for pain relief. And that's just been shown over and over to not be true for most patients. So there have been studies in the ER where they'll use Toradol, and instead of using 30 or even 60 milligrams, they'll use doses of 10 to 15, and they show that it's just as effective. I've also seen the same evidence for ibuprofen, that something like a 400 milligram dose may be just as helpful. Yeah, I don't know. To be quite honest with you, when I use ibuprofen, I tend to use doses. I start off at like 600, but I try to quickly get down to 400 if I can. If I think they have some type of risk or I'm just not sure, I'll just play it safe. Last slide on NSAIDs. I remember as a resident, I was looking into sort of, is there evidence that one NSAID is better for a specific condition? Because they all have slightly different effects in chemistry. And I'll be honest, I didn't see a lot of good evidence for one thing versus the other. There has been some evidence out there to use a specific NSAID for one condition. And so I've kind of listed those. There are other things out there, but I want to do the ones that I thought we see the most. So diclofenac has been shown to be probably best for knee arthritis. So that's the med that I would go for. And the way to remember that is that Voltaren gel, which we use for, it's a topical NSAID, that's been the one that's been shown most helpful for knee pain. And so you can take that orally or you can put it on topically. When it comes to chronic pain, I've seen some suggestions that naproxen can be helpful for that. And I think the reason for that primarily is just because it's dosed twice a day. And so it's easier for people to use. And they mentioned that here, it's got a longer half-life, which I think is quite helpful. It allows patients to take it when they need it. If you're, sometimes like opioids, you need to prescribe every 4 hours. That's a lot. You're taking that 6 times a day. And so people's lives revolve around that. And if they, might miss a dose or they might be doing this stuff outside and they may not have access to it. So I do like having meds that are prescribed twice a day. I think anything after that, it starts to get more challenging to take. I know that for me personally. As I mentioned, Celebrex is a COX-2 inhibitor that I like, and that's been also shown to help with arthritis. Like I said, I use doses typically about 100 milligrams twice a day. And then Toradol, short-term pain management, it's usually done in IV form. And as we mentioned before, you can give small doses, 10 to 15 milligrams. I would use that. I don't think there's a strong argument for using bigger doses. You're just putting people at risk for more side effects. Okay, next slide. I think this is really interesting, and there's multiple reasons why. But probably one of the most reasons I think it's most interesting is because they're kind of using AI, so machine learning tools to go through people's electronic medical records, and they're trying to pull out data from that. And I think we're going to see a ton of this more in the near future. It's going to make research a lot easier. I think the limits is sort of the data that we can collect from electronic medical records, but I found this very interesting, and I remember coming across this article, and we talked about this article in our journal club. Essentially, what the theory was that SSRIs appear to prevent stop an enzyme that may convert prodrugs into the active ingredient. And so prodrugs are things like codeine, tramadol, which we're going to spend a second talking about too here in a little bit. But the one that they actually tested here, which I did not know was a prodrug, that's hydrocodone. And so that's what's in Norco. And so the theory was that if you're on an SSRI, you're on Norco, do you have worse pain scores, worse management of your pain because the SSRI is blocking that enzyme? They actually found that it was true. So they followed people at the right after surgery, at the 3-week mark, and then several months outside of that. And they did find that patients on Norco and SSRIs reported higher pain scores than those that were not. So they had 4 types of patients: those with SSRIs, those without them, and those on Norco, and those on other opioids. And so essentially, I think there's 2 things. Number one, if you have a patient who is on SSRIs and they're on Norco, that's not necessarily a reason to stop them or get them off of it. If they find it's helpful, you can continue it. But I think that we should realize that if you're looking at this patient and they're using doses that are bigger than you might expect, this might be why. And so as palliative care physicians, I think these little tricks are helpful because we're supposed to be the expert in pain management. And when we get a patient, it's most likely because the primary team has tried other things and they're not sure what to do. So when we come on board, I think we should be aware of these things because it may mean the difference of getting their pain controlled. And so either consider a bigger dose of Norco, and I tell this to the patient sometimes. I'll say, look, these may be blocking the total effects of that medicine. So we may need a higher dose. And then when they're telling you they need that higher dose or the higher frequency, you're not surprised. Or you just put them on something like oxycodone or morphine. So as I mentioned, hydrocodone is a prodrug, but so is tramadol. And what I think is interesting is we're going to talk about tramadol. Tramadol, some people love it, some people hate it. And I find all kinds of very strong opinions about tramadol. And that's the reason why people primarily either like it or don't, I think, is because of its metabolism. Some people get hardly any relief, and some people get great relief on it. My experience is that most people don't get a ton of relief on it, but people who do, they say, oh yeah, that really helped. And it's an interesting drug. It works through not just mu receptors. It's a weak agonist on the mu receptor, but it also works through neurotransmitters, so norepinephrine and serotonin. That is reason why it has good pain relief. It works sort of like an SNRI plus kind of a light opioid. But also, because it works through serotonin and norepinephrine, those are reasons why we got to be a little careful with some of the side effects. And so because of the serotonergic effects, the risk of seizures is lower or higher. The risk for the seizure threshold is lower. So that's something you got to be careful about. Serotonin syndrome is something you got to be careful about. If you have people on several medicines like methadone or Zofran, these all have effects on serotonin. And then, of course, dependence and abuse. I don't see that as often, but it certainly is a concern for sure. And then other side effects, nausea, dizziness, constipation, all those things we should be aware of. So tramadol, this is surprising to me. I did not know this was a side effect years ago, but hypoglycemia is actually a pretty big side. It's rare, but it's a big deal. And people have a 3 times increased risk of rehospitalization for hypoglycemia than other treatments. And this is consistent between all patients, not just those with diabetes. And so if you're starting tramadol in older folk because you're afraid to use full opioid agonists, you've got to talk about this because the first 30 days, they're at higher risk for falls. And that can be a really big deal. Other things is that there's an increased risk for hip fractures after um, using tramadol. And that's particularly more present in those that are older than 60. So as we know, hip fractures are a huge deal. And so if you're starting tramadol, this is something you should be talking to families about, and you should be talking to patients about. I wanted to understand sort of, I was reading all this stuff. Tramadol has increased risk of rehospitalization. It has these increased risk of hip fractures and falls. And I thought, okay, well, what is the risk for regular opioids, full mu receptor agonist? Is the risk higher? Is it lower? I would imagine it would be increased, but not as high as opioids, because opioids have their own issue too. A lot of opinions in palliative care, they'll say, why go for tramadol? We don't know the effects are. Just go for the full agonist. Just start somebody on morphine. I don't think that's a bad argument, but I also think if you're considering tramadol, start them on tramadol. If you come back the next day and they didn't get any relief, well, you stop it. We don't have good tests that tell whether they're hypermetabolizers or if they're slow metabolizers. So you just try it. And the reason I say that is because when you look at new tramadol users versus new opioid users, the risk is still quite high in opioid users. In fact, it's higher for most things. They're close, but the risk is still there. So I'm not sure that you're mitigating those risks by just starting them on morphine or some other opioid. And so I've labeled some of the risk here. ER visits, new tramadol users, 80%, new opioid users, 120, increased risk. Falls and hip fractures, we're talking 59 versus 69. Cardiovascular hospitalizations, 41 to 66. That's interesting. One at the very bottom, all cause mortality. That surprised me, considering that all the risk is increased higher with opioids. For some reason, tramadol users, all cause mortality appears to be higher. I think the one question I have that I would probably look more into would be, if we're starting somebody on tramadol versus opioids, they're probably different patients, and those are different risks. And so I wonder if the different type of patient is the reason why we see maybe possibly different risk for different things. Okay, I want to end this lecture, I have about 10 more minutes, on non-pharmacological treatments for pain. I find this very interesting. It was sort of the reason when I was a resident that I became even interested in pain management at all. We, as residents and students, we kind of coming out of this opioid crisis. And so I think we need to sort of get creative and think about pain differently. And so this was one of my special interests. And actually, I spent time at Mary Free Bed with Dr. Hudson when he was there. He's not there anymore, but they have a whole clinic that essentially uses this approach. So not trying to get people off of meds, trying to reframe the way we think about pain. And frameworks are incredibly important. And the way you look at pain in your framework, the way you is going to dictate the way you treat patients. And so I think that we need to consider pain as more than just an injury of the tissues. We all know that stress and anxiety and trauma, they all have an effect on the way we perceive pain. In 1977, there was this guy named George Engel. He wrote a really important article, talked about the need for a new medical model. He argued against a biomedical approach, which was sort of how we were doing things back then. Like I said, we saw pain as really just activation of nociceptive receptors. And so, of course, if that's what pain comes from, you're going to treat them with opioids. But if we have a new model, we think of pain as something more than that. And that's what he argued, is that this biomedical model was reductionist and it was insufficient. So he came up with a more sort of holistic approach. And so a new framework we call biopsychosocial. The name tells you everything you need to know. It's not just medical, biomedical. It's also psychological, and it has to do with people's social situations too. And that really changed the way people did research. It changed the way they thought about medications, how to get people off of it. And it is how we are taught pain nowadays. This is a really neat book. So I want to kind of go over a few resources that I think you guys should consider. I have this in my office if you guys want to check it out. Dr. Hudson at Mary Free Bed, they used to have all these kind of interesting artwork about pain in the clinic. I don't know if it's still there, but that was from this guy's book. This Mosley guy is a physical therapist in Australia. And the whole idea of this book is that pain is more than just this activation of a nociceptive receptor. There's so much more there. And he reviews all the uh, different studies that have shown that basically that is just not true and that there's a lot of other inputs. So we know the output is pain. We know that one of the inputs is nociceptors, but there's a lot of other inputs. And we see that when people are more stressed, when they've gone through trauma, the output for pain, the way they perceive pain is very different. One of the key points of this book is that basically pain is all about protection. So it's your body trying to protect itself. And he writes in this book that basically the activation process of nociception, it's necessary for pain, but it's just not sufficient for the experience of pain. And he basically argues that if we reduce pain just to nociception, you're causing, you're making an error, a logical error of reductionist fallacy. So we're reducing some complex system down to a subset of its components and acting like that represents the whole. And if you do that, you're essentially missing out on a huge part of how we treat pain. And so this, want to give a shout out to Mary Free Bed. They have a whole clinic. It's very intense. It's multiple weeks. You see the patients go there multiple days, and it's right next door. So it's a great resource in our community. It is challenging for some patients to do. I admit that, but they see all kinds of patients. And any patient that we think that has different parts of their pain is, they've been on treatment, it hasn't gotten better, they've maxed out, their quality of life is worse, they're depressed, they have anxiety, they're overusing their medications. All those patients would be good patients to consider for the Mary Free Bed, because part of their job, you'll see a physician who tries to get you off of some of these medications. You also see a pain psychologist. I met with that psychologist. He wrote a book on it, so it's very neat. He walks you through different ways of trying to, like, mindfulness or biofeedback, and he would do some of that in the room with the patients. And then they also see physical therapy and occupational therapy. And I think that's great because a lot of these patients have had chronic pain for a long time and they don't want to move. They're afraid that if they do activity, they're going to cause more pain. And so part of this process is helping them move in a safe and controlled setting and reworking their brain, telling them this is okay, this is safe, while they're doing psychological work with the therapist to try to feed their pain differently. And then, of course, during that time, you have a provider who's trying to get them off of some of these meds or at least reduce them so that they can be more functional. Dr. Hudson wrote an article. You guys should check it out. It was from 2019. And he essentially has talked about what I have been talking about, that frameworks matter, that to determine a good treatment, we've got to come up with a good framework. And he makes the argument that essentially bad frameworks is what caused the opioid crisis. This was in the Washington Post. And he kind of discusses sort of similar things. He talks about back in the day in 1965, we had this gate control theory, and that's been basically replaced by what he calls not him, but what's called a neuro matrix model. And it just views pain as complex experience shaped by multiple things more than just biology. So he argues for sort of a more holistic approach to pain. This is another resource. This is from a physician, Dr. Schubiner. He does courses for providers. He's actually from Southfield. He is the director of the mind-body medicine program at Providence Hospital in Southfield. And he's also a professor at Michigan State. But he has this whole book. I like this. This is really good. It's a 28-day program. If you buy the book, you get access to meditation audio stuff on his website. It's pretty neat. And I think this is really good for those that are motivated, who maybe see a therapist, who like doing things like journaling, or I have had several younger patients who have chronic pain and I don't want to start opioids. And a lot of that is their pain is, because they're anxious and maybe they've had some trauma. And so I like this because it's basically a workbook that they can order. This is the last resource that I think we should all be aware of. It's pretty neat. It's an app called Curable. If you reach out to them, they can, as a clinician provider, they will actually give you, I think, like 6 weeks or 2 months of free access to this. But it's nice because it's on your phone. It's just like the book that I mentioned, but it's basically all in an app. And what's neat about it, say your patient has a pain crisis and they're suddenly a 10 out of 10, they can go on the app, they can push this specific button that will kind of walk them through different steps to try to reduce their pain. And there are nightly different things like journaling and meditation that they can walk you through. And so you can kind of you can tell the program sort of things that you find interesting or that might be helpful, and then they will walk you through it. And it is a paid prescription, but the interesting thing is, I didn't know this, but you look through their board of directors, and Dr. Schubiner is actually one of the physicians on that. So I thought that was kind of interesting. Okay, that is the end of the lecture. And these are my citations. So, we don't have a lot of time, but if we have any questions, I think.
Yeah, thank you. That was wonderful. I feel like every time you give this talk, Brett, I am reminded of things I have forgotten and always learn new things as well. So thank you.
Yeah, you're welcome.
I have a couple questions. On the LDN, there seems to be a focus on the endorphins. Why is the dosing at nighttime? If it seems to be like vivid dreams and endorphin activation, it seems kind of counterintuitive.
Yeah, I think that's a good question. I don't remember the answer to that. I think that's because, gosh, I don't know the answer to that, but that's a good question.
No, I just found that interesting that that's listed as the
one physician that I met originally, the PM&R doc, said that if you can prescribe in the morning, that's fine, but there's something that I don't clearly remember, but it's something to do with the dosing of it, that it's preferred at nighttime. But I think whether you get it morning or night, you're still going to get the vivid dreams. I'm not sure that will change that.
Okay, and then my other question was about the tricyclics. Well, twofold. I've been on amitriptyline for post-herpetic neuralgia after shingles, and I find it profoundly sedating at very low dose initially. In fact, having to take it at like dinner time rather than bedtime. And my husband, Mike, was like, they should really think about nortriptyline. And I'm just wondering why as you said, you're leaning towards nortriptyline as first line, why we're continuing to prescribe prodrugs like amitriptyline, codeine is kind of off the top list, and even hydrocodone, when we know that we can have a better, effect and expected side effect profile with the actual drug.
So first, I'm not sure that amitriptyline is considered a prodrug. It does get converted to nortriptyline, but amitriptyline by itself does have effects. And I want to address both those questions. First, I do prefer nortriptyline. I think it's an option. If it is sedating, and you're not the first person to tell me that. In fact, almost everybody says that to me. That's why I just start with nortriptyline, because I find that people can kind of sleep it over. They take it at night, they sleep over it, but they still wake up feeling pretty groggy, and it's hard. Now, why are we prescribing prodrugs like hydrocodone? I think it's because a lot of people get benefit from it, and Norco's a helpful drug, even though it's a prodrug. That's an interesting question, because I had the same question. Like, when we do tramadol, we do codeine, it's obvious that some people get benefit and some people don't. But I don't see that with hydrocodone, and I wonder if it's because the enzymes are more consistent between populations. And so probably most people get benefit from Norco. It's more like consistent relief, whereas tramadol, if you're not converting it, you're not getting benefit. I think most people will convert hydrocodone to its active ingredient. Where we get into a sticky situation is when we're on SSRIs that block that enzyme. So now we're introducing something on the outside that do that. So
like patients on Cymbalta for chronic pain, which is a real common like I would presume then those
I would
patients
too.
would not do well with Norco.
Yeah, so I mean, I think that's why I said, if they're coming in, say in the hospital, I think you're right. I think maybe it's if they're on an SSRI, it's a good idea to possibly consider a different drug, oxycodone or even morphine. I don't think you necessarily have to. I think just being aware that you may need a bigger dose than what you would expect and letting the patient know that. I think if they're coming in the hospital and you have the opportunity to switch it while they're in for surgery, there's probably benefit in doing that anyways, because you probably will get a little better pain relief just from the opioid rotation. And you can always put them back on Norco. But I think the biggest thing here is just the same with tramadol. You just have to give them the med. If they want to take Norco because that's what they've been on, it's combined with Tylenol, they may like that. Then I think just being aware that you may need a little slightly bigger dose than what you would expect.
Okay, and then sorry, one last
Yeah.
thing about the tricyclics. I'm ER background, and these drugs with the, obviously tricyclics at higher doses for depression, we've gotten away from because we have newer drugs. But the use of these for pain, which I think is great, is my concern is always the narrow therapeutic index.
Yeah.
I mean, a single bottle of, speaking from someone who had amitriptyline in her house, I calculated that if I just took that 1 month supply in a sitting, I would be dead. Meaning, if you have someone with, because it's a sodium channel blocker, tricyclic antidepressant overdoses is one of the most serious cardiovascular toxidromes that come in, which has stopped because it's no longer giving it for depressed people. But people with pain often have, overlapping, probably bad days. And I just, and also like the one pill that can kill for kids too. It's just like these drugs are great, but they have a very narrow effective to lethal crossover. So I just don't know if that's ever talked about in like palliative.
Yeah, certainly. I think it's a really good point because I find that to be true too. And that's sort of some of the things I talked about in this lecture was that I prefer much smaller doses. And if I get to the range of 75, I tend to think that I need to stop there. And I try not to even get there because I think that's probably too big of a dose for most people. Some people do just fine, admittedly, but I think you're right. These are real issues. And the challenge with like neuropathic pain is that we tend to, and things like fibromyalgia, is that we don't have a lot of good, perfect treatments. And so we stack a lot of drugs and we continue to increase doses. It's like gabapentin. I find that people who are on like 3,600 milligrams a day, it's sometimes asked like, how much benefit did you get when you were taking 900 versus 1,200 3 times a day? Like a lot of times it's not a huge jump, but yet we're exposing people to a ton of side effects. And so I try to keep people at the lower levels because of that reason. And I think if you're, it's fine if you got people on a 10 or 25 milligram dose at night, that's fine. I think you're probably safe there, but you definitely should be talking to patients, letting them know that these are serious issues, and that they need to be, like you mentioned with the kids, you need to keep them in a safe area, that they're not just benign medications. Yeah, I appreciate your questions.
Any other questions out there?
I have one. Just off the top of your head, what are the more common prodrugs? I mean, you mentioned codeine, hydrocodone, tramadol. What are just? I mean,
yeah, that's a good question. I don't know if anybody else has any thoughts.
I don't know I don't need an exhaustive list. Just curious.
Yeah. Well, the ones that I mentioned are the other ones that I guess I'm aware of. Mostly codeine and tramadol.
All right.
Tramadol is the one that we are all aware of. And then, of course, the hydrocodone. The other opioids are not prodrugs, though. And the other, I can't think of any other drug that we use on a consistent basis that's a prodrug. I don't know if anybody else is aware of it.
Well, sort of.
All right. Well,
Brett.
Yeah.
if you don't mind stopping your screen sharing, and then we'll move on to the case for today.